delighted to have Dr. Mark Eccleston-Turner here with us today. He's a lecturer in law at Keele University, and this is my favorite. So his research specialism is in the field of international law and infectious diseases, which is fun because it means that we get to work with him a lot of fun things. And specifically, a lot of his work lies in exactly what we're going to be talking about today: pandemic influenza preparedness, access to vaccines, the international health regulations, and the law of international organizations in the context of global health, which is, again, what a lot of the stuff that we worked on, so we have the fun of collaborating with Mark on a bunch of different projects. Just to embarrass him really quickly, holds a Bachelor's of Law from the University of Wales.
No, say the next bit.
I'm not going to. I've never been able to say it right. You say it.
Aberystwyth.
There we go. And a Master's of Law with distinction in medical law and ethics from the University of Edinburgh. And his doctorate was from the University of Manchester, with a title a little bit familiar to what we're going to talk about today: the right to health and access to pandemic influenza vaccines. So Mark's been working on this topic for a little while, and delighted to have him here. He is also an LB fellow with Hopkins, and has been doing some work as a consultant to WHO. So, and is very importantly a member of the ILIAD consortium, which Alex got up, the International Law, Impact, and Infectious Disease consortium that we have started and is growing, and is a community of legal and governance scholars focused on international health law around the world. So with that, Mark, you just missed the ILIAD introduction.
Okay, thank you very much. And thank you all for coming here so early on a Friday morning.
Oh, hey, sorry, Mark, even before we get going, can we do a quick introduction so you know who everybody is?
Yeah, that would be great, actually.
Here, you want to
Yeah,
start?
happy to start. So hi, good morning. I'm Alba Vilachelio. I'm a medical epidemiologist. I work at PAHO, an American Health Organization, which is the WHO regional office for the Americas, and I work in influenza vaccines for Latin America and the Caribbean.
Right.
Hi, I'm Josh Michaud. I'm with the Kaiser Family Foundation, also Johns Hopkins University School of Advanced International Studies.
Hi, I'm Jessica Lynn. I work at the Center for Global Health Science and Security at Procurement.
Hi, I'm Alexandra Phelan. I'm at the Center for Global Health Science and Security and the Law School here.
Colin Carlson, postdoc in biology, center affiliate.
Trish Foley, I'm a veterinarian. I'm in the Department of Microbiology and Immunology.
Nancy Connell, Center for Health Security, Hopkins.
Ryan Rummel, I'm an undergraduate here in the School of Foreign Service in Science, Technology, and International Affairs.
Cameron Kiefer, I'm a AAA Science Fellow at the State Department in International Narcotics.
Christopher Moore is a professor of global health over at George Washington University.
I'm Emily Carl. I'm a global health student here.
Kate Stevens, also a AAAS Fellow, U.S. Department of State, Office of International Health and Biodefense.
Scott Davis, same.
Park, basis government bureaucrat. Battening on the taxpayer.
Jessica Petrillo, Senior Advisor for Health Security at the State Department.
My name is Sam Pasco. I'm actually here for graduate school interview for microbiology PhD program talking cats and elephants.
And as I mentioned earlier, coffee's being set up. It was a little late today, so as one needs their caffeine, please just...
We're ready to go.
Even better. So as folks need to please head out, get some coffee, and make sure we hook up Mark immediately. So.
Thank you very much. And thank you all again for coming. It's really appreciated. So what I'm going to be talking about today is access to influenza vaccines during a pandemic, particularly how the PIP framework works or is intended to work, and how I think it will be operationalized during an influenza pandemic. So I think a starting point for this would be to go back to 2009 H1N1 and to look at how developing countries in particular actually gained access to vaccines during that time. The vast majority of developing countries received their vaccines through the World Health Organization. Thank you. Vaccine Deployment Initiative, the VDI. This was an ad hoc system set up to distribute vaccines to developing countries. And they distributed around 78 million doses of vaccine. where those vaccines came from is the important bit. Those vaccines were donated. They were donated by developed countries. They were donated by the United States, the UK, France, Australia, Canada, and so on and so forth. And distribution from the VDI was successful once those vaccines had actually been committed and once they had actually been donated. The problem was these countries had donated around, had pledged 120 million doses to WHO to pass on to developing countries. However, they delayed significantly transferring those vaccines to WHO. There was around a 3-month delay from the commitment being made to actually being fulfilled. And the timing of that commitment is quite interesting. So on the Friday, 2 papers were published in the New England Journal of Medicine. One was a large study which pointed out that 2009 wasn't actually the sort of major pandemic which we were afraid it was going to be. Actually, it's quite low level. And the second paper demonstrated that you could provide full immunization against 2009 H1N1 with a 1-dose vaccination strategy, not a 2-dose. So typically for flu pandemics, you can require 2-dose vaccination strategies. So those 2 papers were published on a Friday. Monday morning, the US, the UK, Canada, France, Australia suddenly shipped all of these vaccines, which we'd been long promising. Because suddenly we had twice as many vaccines as we thought we did. We only needed to give a 1-dose strategy, not a 2-dose strategy. And this was this was very clear from the US government's justification at the time. As the US is flush with enough vaccines, the long-promised donation is ready to ship. So what we did, what these developing countries did was hold on to their vaccine stocks that they had promised to WHO until they were assured that they had enough to meet local demand and meet local need. And this was obviously sort of considered to be not an ideal situation with which to work in, because the shipment only came during 2009 because this assurance had been given that actually a 1-dose strategy was required. We didn't need as many vaccines as we actually had. In response to this, and also in response to the Indonesian virus sharing incident, where Indonesia withheld viruses during 2005 H5N1, the World Health Organization passed the PIP framework. This is a set of regulations which are intended to ensure access and benefit sharing for pandemic influenza vaccines and viruses. Now, on the vaccine side of things, the PIP framework is operationalized through a series of contracts which are called standard material transfer agreements. So vaccine manufacturers need access to viral samples to manufacture and research, and in return for access to those viral samples, they have to do at least 2 of the following. So they have to donate real-time vaccine production to WHO, so not the process which happened in 2009 where we waited until we had enough, there was a huge delay. Manufacturers are meant to send real-time production to WHO or reserve it at affordable costs for purchase by WHO. And this is the model which was passed in 2011. It's not been tested yet, obviously. We've not had a major pandemic. But this is meant to stop the ad hoc nature of vaccine donations, which we saw in 2009, whereby countries just waited until they had enough and then they give vaccine to WHO to pass on to developing countries, meaning that developing countries got access much later, and much later in the outbreak, which is when the vaccine is less efficacious, it's less required, and there is a clear issue there of global health justice and access to medical goods. PIP was meant to solve this problem. And one of the things that I work on, and one of the things my PhD wrote about is, did it or does it? During the next pandemic, will this work? Will this ensure that developing countries get access to the vaccines they need in good time? So at present, 13 out of the 25 manufacturers around the world who can make pandemic influenza vaccines have signed up to an SMTA, actually have this agreement. Now, the guidance put forward in the PIP framework is that manufacturers should donate 10% of their real-time vaccine production to WHO. When we look at the actual terms of the agreements, there's significant variation as to what manufacturers have actually been willing to agree to. So GSK have donated around 7.5%, Sanofi 7.5%. So if you had agreed to donate and reserve, based on the PIP framework guidance, that should have secured 20% of Glaxo's real-time vaccine production for WHO. The reality is it's secured 10%. So that's a problem there in and of itself.
Are all of the commitments public?
Yes, yes. So the commitments which they made are all publicly available. Term sheets are not publicly available, which is something we'll talk about in a moment. One was accidentally posted online, and everyone who is interested in pandemic influenza vaccines immediately downloaded it, because that's not sticking around very long. I want that. So there's a problem with the number of commitments which have been made. So whether the stockpile will secure the number of vaccines which it set out to secure is one thing. But
Can I ask one?
yeah, sure.
So 13 of the 25 manufacturers, is there any sense of whether we got the right ones, or the big ones, or the most important ones?
So the big ones have secured those commitments. So the major players in the field do have them. People like Seqirus, GSK, Sanofi, the Serum Institute of India all have SMTAs. So that's good. But there are 12 manufacturers of pandemic influenza vaccines who believe that they can operate outside of this framework and don't require the SMTA, or are currently negotiating an SMTA. Because we don't know who is currently negotiating and who is not. So there may be manufacturers who are currently negotiating one of these agreements with WHO, or they may think that I don't need one of these agreements, I can still operate in this space without an agreement and get access to viruses elsewhere through the bilateral virus sharing system. No, there's silence. Yeah, that's us trying to work out why do these 12 not have them. So this term sheet got posted online. So the front sheet of the contract, essentially a very watered down version of the contract, for every manufacturer where it states what they've actually committed to is available online. Lots of the detail of the contracts are in what's called the term sheet, and the term sheet is not publicly available. WHO accidentally posted their term sheet with GlaxoSmithKline online, and lots of us who work in this field very excitedly downloaded it and shared it with each other, thought that should not be available, but I'm going to have it anyway. So one of the things which transpires when you read through the contract is there is a force majeure clause. Force majeure is a clause which is in all contracts, and it basically sets out the conditions on which the failure to perform your contractual duty does not render you legally liable. It's not whether this actually counts as force majeure or not is not necessarily important at this stage. But one of the things which the agreements between the vaccine manufacturers and WHO anticipated is the possibility of embargo or requisition or acts of government or judicial order which prevents failure, which prevents the manufacturer from being able to perform their contractual duty. So essentially, the government in which the vaccine manufacturer is based doesn't let those vaccines ship to WHO. Now, pandemic influenza vaccine manufacturing is very limited. So first of all, we don't make enough vaccines, and we cannot make enough vaccines to meet global demand. But also the manufacturing capacity is geographically limited. It's geographically limited to a very small number of mainly developed countries. Some developing countries have come online through the GAP program, which WHO has run over the last 10 years. But overwhelmingly, the capacity is based in the global north in a small handful of countries. So there is a problem there. So if someone like the UK, for example, chose to use government powers to stop vaccines from leaving the country, that could have a huge impact on the global supply of vaccines to WHO, which I'll talk about now. So what this project has become interested in is how likely is this to occur, and what is the legal means by which it would occur in the UK? So obviously that's where I'm based. Is everyone with me so far? Does anyone have any questions at the moment?
A question, but just a supposition. My immediate reaction would be the likelihood of that happening is directly correlated to the degree to which there is really a desperate need for that vaccine in the developing world. So the worse the problem is, the worse the problem with addressing the problem is.
Exactly, yeah. The one time we really need this system to work is the time that it's most likely to fail. And that's a real problem. And you have to remember, in terms of those who don't really work very much in the influenza vaccine space, it takes a long time to manufacture a new influenza vaccine. So we're talking, once, at the point we realize that a virus is circulating which has human pandemic potential, we then have to begin the switch over from seasonal to pandemic strain manufacturing. That takes around 6 months, best case scenario. So during those 6 months, there will be no vaccine available whatsoever. What we will have available to us is Tamiflu, and we all know how good that is, and social distancing measures. Those are the only things which will be available for the 6 months, that 6 to 7 month period. The global manufacturing capacity is estimated to be anywhere between 4 and 6 billion doses a year. But it's not really a year, it's in 18 months. From the point we realize this is a pandemic strain, it will take us at least 18 months to make around 4 billion doses, realistically. If it's an avian strain of influenza and the egg supply is compromised or damaged in any way, so pandemic influenza vaccine manufacturing relies on egg-based technology, we could be looking at halving the global dosage that we can actually use if we don't use adjuvants well enough. So during that time, so 6 to 7 months of a pandemic strain circulating the globe, at that point the first load of vaccines roll off the production line. At that point, 10% of those vaccines are meant to leave manufacturers based in the UK to be shipped to WHO to ship onward to developing countries. Now, WHO's position is that this will happen and the SMTAs will be respected and will be fulfilled. This project looks at to what extent that is actually true. So in the UK, we have the production capacity to produce around 160 million doses of vaccine per year. The UK government holds an advance purchase agreement with both manufacturers who are based within the UK to secure essentially the full load of a first-year dosage. So the contract which the UK government has with these manufacturers says that the first 130 million doses which you provide comes to us. These same manufacturers have contracts with WHO which says 10% of that same production capacity needs to go to be shipped to WHO. So when you look at the manufacturers who are based in the UK and what they've committed to WHO, 15% of the real-time production capacity of the UK is meant to be donated to WHO in real time, and a further 20% of that manufacturing capacity is meant to be reserved for purchase by WHO at low cost. So, if WHO chose to buy the full lot that they have reserved and the manufacturing commitments which are in SMTAs are fulfilled, apparently 35% of the real-time vaccine production capacity in the United Kingdom is going to leave on a real-time basis during a pandemic. My question is this going to happen realistically? Well, my argument is that it will not. My belief and my hypothesis is that the UK government will use emergency powers to prevent those vaccines from leaving the country. During 2009, we did everything in our power to frustrate the donations and delay the donations to ensure that the UK supply was secured, and that was in a pretty mild, fairly low-level pandemic. In a more severe pandemic, which, as Chris pointed out, is the time that we really want PIP to work, is the time that it is least likely to work. So the legal position in the UK is that we have the Civil Contingencies Act. The Civil Contingencies Act is the act of Parliament, the piece of legislation, which lays down emergency powers for government. So it allows the UK government to declare a state of emergency and allows the UK government to have additional powers during that state of emergency. So Section 22 of the Act says that the UK, a senior minister of the Crown, so this doesn't have to be just the Prime Minister, this could be any senior member of Cabinet, although it is likely that this would be decided through COBRA and be decided through cabinet meetings, has the power to confiscate property with or without compensation under this set of emergency powers. And it is my hypothesis that during a serious influenza pandemic, we would use these powers. So Section 21 defines an emergency as something that has occurred, is occurring, or is about to occur, and regulations are necessary to prevent or mitigate the emergency. And we're talking about mitigation at this stage. Problem is, there's no precedent. So as lawyers, we like precedent. We like to look at past cases or past examples which tell us how the law will operate in the future. The Civil Contingencies Act was passed in 2004. It has never been used. We had previous legislation on emergency powers dating from the early 1900s. And when you look at the circumstances in which the UK government has used emergency powers, it's almost always been to requisition land or manufacturing bases to help with the war efforts. It was used a lot during the Second World War and partially during the First World War. But it tends to be to help the war effort. Now, the Civil Contingencies Act was passed because there was a recognition that there are a wider scope of emergencies to which the government may need to respond rather than just the war effort. So the next question is a pandemic... So we have no precedent for using the Civil Contingencies Act. There was some planned usage for using the Civil Contingencies Act to respond to a no-deal Brexit when there were some concerns about food supplies or medicine supplies. There were plans drawn up by Cabinet to potentially use the Civil Contingencies Act to take control of infrastructure in that way. So, the Cabinet Office, the UK Central Government Office, talks about the circumstances in which they would consider using the Civil Contingencies Act and the powers under the Civil Contingencies Act. And it talks about a catastrophic emergency, a level 3 event, which is considered to have exceptionally high and potentially widespread impact, requires immediate central government direction and support, such as a major natural disaster, and whether local response has been overwhelmed or the use of emergency powers were required to direct the response or requisition assets and resources. And they also provide this handy little table to identify what a level 3 is. So level 3 events are required central direction from COBRA, which is the meeting of government with military and emergency services. So we're talking about an event which dominates the party or national debate, requires central direction from government. It is overwhelming services at the local and regional level. But this guidance doesn't actually indicate any events which would count as catastrophic events. So it's the guidance which have been provided by the Cabinet Office is not clear about what actually constitutes a catastrophic event where these powers would be used. So we have to dig a little bit more deeply. So what counts as a catastrophe to the British people? Maybe it's that. Maybe it's that. It's definitely that. So what we have to work out is an influenza pandemic a catastrophic event in which the government are likely to use civil contingency powers and use those powers to requisition assets, such as vaccines? So it's very clear from the guidance on pandemic influenza that an influenza is one of the circumstances which government anticipates to be a catastrophic event. So we're talking about one of the most severe natural challenges likely to affect the UK. Many millions of people around the world become infected, 50% become ill with symptoms. A variable proportion will die, up to 1/2 of the population may become infected, and between 20 and 750,000 additional deaths may occur in the UK. And in the absence of early or effective intervention, society is likely to face social and economic disruption, significant threats to the continuity of essential services, lower production levels, etc., etc. It seems quite clear to me on the reading of this, an influenza pandemic is a catastrophic event within the meaning of the Cabinet Office guidance for the Civil Contingencies Act, and that in these circumstances, government would consider using the Civil Contingencies Act to make emergency regulations. And the idea of us being 7 months into a pandemic and 30% of the real-time vaccine production in the UK is just meant to roll out the door, I think that would be something which the UK government would respond to. We like to talk about cosmopolitanism and internationalism, and what we see whenever there is a pandemic event, what we can see with coronavirus now is that states are inherently self-interested and inherently self-regarded and actually quite irrational in the way in which they respond. And even when we saw through 2009, we were very happy to promise 120 million doses to WHO. We were not happy to let that go until we were secured and happy that actually we'll be okay. And I think that an influenza pandemic is one of those circumstances. And requisition of assets and requisition of vaccines is probably one of the only things which is going to be available here. Other than that, there are very few things which the UK government is going to be able to do, other than close schools, close mass gatherings, all of those sorts of things. They don't need the Civil Contingencies Act to do that. That can just occur anyway. One of the other major drivers in this to sort of drive this forward is the fact that government must be seen to act. Government must do something. When you have pandemics like this, when you have events, government cannot be seen to do nothing. It must, you can just imagine how it would play out in the media that 30% of our vaccines are leaving the country on a rolling basis. That would be considered unpalatable to the British population and to populations of any country around the world. This is not a uniquely British problem, I don't think. And the government would act and respond because the vaccine is essentially the one tool we've got in this fight. And the final confirmation for me that we would actually do this and we would actually use the civil contingencies in an influenza pandemic is a meeting of the House of Lords, which did a report on pandemic influenza in 2008, 2009. I just put a photograph there from the House of Lords state opening of Parliament just to make people really confused about what Britain is like. It's a real official. He has a real job. He wears that for his daily work. That's his uniform. So the Earl of Selborne, great title, asked a member of the UK government civil contingency health planning team about the Civil Contingencies Act and about whether it would be likely to be used in an influenza pandemic. And it's very clear from the response which was given is that, it should be viewed as a last resort. It is an emergency power that should be used if they're needed in order to help facilitate the response to a pandemic, but only if the criteria upon which it was agreed are fully met and we've exhausted all other possibilities. I think 7 months into a pandemic, when at that point health services would have been overwhelmed for several months, is the time that we would actually consider using these resources. One of my master's students is a former director of public health for one of the regions in the UK, and he did some modelling of a quite severe influenza pandemic, of use of respirators in UK hospitals. And he worked out that 4 weeks into a severe influenza pandemic, we would have used every single respirator in the country. Every one of them would have been occupied at that point. And his work was actually looking at how do we decide who comes on and who comes off. But this tells you something about the state of influenza preparedness and just how overwhelmed health services would be a month into an influenza pandemic or 6 weeks into an influenza pandemic. By the time a vaccine becomes available, we're looking at 7 months into this outbreak, by which point we would be more than willing to use these powers. Regardless of the agreements which have occurred between manufacturers and the World Health Organization through SMTAs, the idea of SMTAs is really good. The idea that WHO would contract directly with manufacturers is a good idea because in 2009, the holding power was that the governments like the UK and governments like the US bought the vaccines, then decided to donate them. The problem with SMTAs is they fail to take into account the power of the government, power of local governments where vaccine manufacturers are based, and we're talking about a small number of countries as well. So if the UK, the US and Canada or Australia decided to do similar things to what I anticipate happen, that could knock out 20% of the global supply of vaccines which are meant to, which are heading to WHO. And that has a huge knock-on effect down the chain to developing countries. And when you look at developing countries' pandemic influenza preparedness plans, they are relying on donations from this system. They believe that those vaccines will be made available to WHO and they will be transferred to those. And my concern is they will never arrive because we will use these emergency powers. And that's a real problem for global health justice, but it's a real problem for the actual response. And that brings me to the end, so thank you.
Just one question with that. You said never arrive. They won't necessarily arrive in the first tranche, but
So they may arrive significantly later. Significantly.
there's a difference.
So yeah, there is a difference, yeah, but I mean, this whole program was meant to be real-time donations.
I look to the dead, Jessica.
But the wording, I mean, the way the story is told also has an impact, and so just wanted to clarify.
Yeah, okay, so they may arrive at some quite distant point in the distant future, in which case, how is this any better than what we had in 2009? If we're waiting for the goodwill of states, if we're waiting for the goodwill of the governments which actually host this. And that goodwill will be, the more severe the pandemic, the less that goodwill will be, and the later that goodwill will arrive.
Is there any modelling about the sort of, obviously we depend on the flu itself and the nature of the particular strain that we have, but is there any modelling that's done about what a 1 month delay means in terms of people who die? Like if you could factor in all the relevant features. So because for those people 6 months is effectively never.
Yeah.
So is there any sort of data that's been done that you've used in this context?
I don't know if they're.
So, I mean, Gates Foundation has put out a very user-friendly, interactive.
Yeah,
article
the
that's on- printed on
Shook
USA.
Mac. Yeah.
And that was, I think, part of the Bill Gates article in, is it New England Journal?
Yeah.
Was it New England Journal?
Is that the Shook flu map? The one where it
It's the one
shows.
that, like, shows like,
Yeah.
what happens for a 30 million people event, and
Yeah.
if the vaccine's introduced at this time, or if you're at 6 weeks, you get to save 29 million lives.
And Griffon also in the gain of function,
Yeah.
400,000 page.
If you can find the.
Yeah, you have to find it, actually know what page it's on.
Yeah.
But they do the same modeling.
Yeah.
So I wonder that, I think that could be really interesting to sort of map against this.
Yeah. To sort of, if what you could do is model if the UK delayed, what would the impact be on global supply chain? Global supply if the US used similar circumstances, if Canada, if Australia, if these major developed countries which host manufacturing capacity use their emergency powers, the actual knock-on effect would be really interesting to model.
Thank you.
Okay, well, I think I know the answer to this, but is there any legal recourse for the WHO to enforce these contracts even in the light of government's actions? So
No. Well, I mean, they may, if the requisition didn't constitute a force majeure event which renders your legal liability none, there may be recourse if the only people that WHO could bring legal action against is the manufacturer themselves, because that is who they've contracted with. They couldn't bring legal action against the UK government for using these emergency powers. So even if there were legal recourse, it would be against the wrong party, and it'd be later. So you could, after the pandemic was over, WHO could take GSK to a court in Switzerland for failure to perform. But what's the point? The pandemic is already over, those vaccines never arrived. GSK could pay damages to WHO, could pay a financial penalty to WHO, but that's not adequate for the response here. The WHO couldn't get something like a mandatory injunction to force performance, because the one thing which is preventing GSK or whoever it is from performing their contractual basis is the power of the state, the power of the host state, and WHO has no legal recourse against that state.
I want to go to a question, but Bruce, you should probably introduce yourself to our too.
I did a lot. I'll tell you, I did a lot of this kind of work for a while with WHO. But my question is, do you think the manufacturers have double booked? That there's a fixed capacity that they can make, and they don't actually know what it is.
Mm-hmm.
They know how big the factory is, but they don't know how much they can make based on a bunch of biological things.
Yeah.
But they're supposed to have, basically give that percentage. So a day a week or something like that. But do you think they've double booked? So the UK has contracted for whatever.
Mm-hmm.
Have they reserved the WHO capacity and not contracted for that slice of it? Or do you think that they have booked separately, double booked?
That could be the case. I mean, what the problem is that these contracts don't take into account national policies, or don't take into account other contracts, or take into account national policies. So if you take a country like Australia, Australia has an Australian first policy. It is national policy from the government that no vaccine will leave the country until we are satisfied that we have enough. But there are manufacturers based in Australia which have SMTAs with WHO and have commitments to send 10% of their real-time production. So there's a mismatch here between the agreement between WHO and the manufacturer and with the local policies or the local contracts which they have with the host government. Yeah, I think that there is a problem with that. There is a mismatch there. The major problem is that we have very little idea about what these advanced purchase agreements that governments have actually say. So as part of my PhD, I tried to do a Freedom of Information request to get hold of the UK government one, which was refused. I appealed to the Information Commissioner, it was refused, and it was refused on the grounds that disclosing the information contained within the contract wasn't a national security issue. It was that it would render the manufacturer's commercial position to negotiate further contracts to be weakened.
That's a key problem, is because everybody's blinded to that.
Yeah,
from every manufacturer.
we have no idea what these contracts say, really. Yeah, so that double booking. To go back to your question, yeah, I imagine they are double booked.
So that happened in the U.S. We were supposed to get a vaccine from Australia because they didn't plan to use it.
In 2009? Yeah. And now put that up for imagine that same circumstance, a really severe pandemic, something which requires a two-dose strategy. Imagine just how much more difficult that's going to be. Yeah.
I think he was next.
Chris?
Well, just my reaction is that the problem you've identified is absolutely valid, but I think unfixable. Because there wouldn't matter if there wasn't a force majeure clause in the agreement anyway.
It would happen, yeah.
Politically, if the pandemic is severe enough, countries are going to exercise whatever authorities they have and imagine some if they need to address public health needs domestically first, right?
Yeah.
So unless you actually expand the production base, the capacity, you're going to continue to have this problem. And it presumably helps somewhat because in lower level pandemics, or in the case of some hypothetical countries filled with goodwill and love for others, they'll follow through on the commitments. But I guess my question is the other things that PIP does in terms of facilitating sample access and facilitating investment in influenza vaccine production capacity in the developing world. Do those, if you just say, all right, write this off as a loss, is the thing still a net win? Is it, or is the prescription to, in fact, say, well, maybe what we ought to do is shift emphasis from this to greater emphasis on building up the production capacity? And then you get the question of how do you actually create a viable economic model for that that's sustainable, because this is a classic market failure thing, right? When you need it, you need a lot, and then most of the time you need a lot less.
Yeah, I think that's a great question. Just to sort of skip back to in terms of the market failure, it's absolutely market failure. If I just skip back to that. So this is Seqirus's manufacturing plant in Liverpool in the UK. That was almost wholly funded by the UK government. We in developing countries heavily subsidize this industry because we know it is a market failure. The problem is that most developing countries are not in a financial position to be able to do that, and their sort of health priorities are much more immediate and not long-term. There may be an influenza pandemic in 10, 15, 20, 50 years. So that's the huge problem. In terms of if PIP has been a success, in terms of the other things which PIP does, when you actually sort of look at virus sharing and whether PIP is facilitating that, there are a number of sort of major gaps in the viruses which are logged in PIP's system, and it appears that bilateral virus transfer is occurring on a wide scale outside of the PIP framework. So there have been a couple of articles which have looked at the sharing of H7N9 samples around the world, and there are very few samples of that which have been shared with the PIP framework and put into GISRIS through PIP. So there does appear to be a failure on that part when it comes to PIP. I'm not necessarily saying tear this down. My point is we should not have the faith in this system that we appear to do. So I think that that's quite dangerous faith, and the one time we need this system to work is the time it will fail. And I think that it's a real injustice to developing countries that they are relying on this system as being something that will work, and in fact it will not. I think that's a real problem. I've presented this paper at a conference where the moderator was the WHO team lead who is in charge of this system, and his comment was, no, you're wrong. This will work. UK will not do this. US. If I'm wrong, I've published a couple of papers in academic journals which have turned out to not be proven correct. I could live with that. If I'm right and WHO is wrong, and this system will fail, that has catastrophic implications for developing countries. And I don't mean sort of this type of catastrophe, I mean a real catastrophic impact. And that's the problem, is that we need to not have the faith in this system which we appear to have.
No, my reaction to that is, I don't know whether my first reaction was, oh, that's so sweet. And then I was like, oh, Jesus, that's scary too.
Yeah.
So the market failure is actually on seasonal influenza, not pandemic.
Yes.
So there's been a huge investment, you mentioned it, about increasing production capacity in other places. And there are investments mostly made by the US government in WHO to start up manufacturing in places where people had the capability to do that.
Through GAP.
Most of those have been a failure because, not because of the technology, but because they didn't have a business model. That they were mostly interested in having a pandemic vaccine, they were less interested in the seasonal vaccine. And in a country like India, they were looking to export. They would make vaccine, but they were going to export it because they said they couldn't find a market within India because they assumed the government would purchase it. So the fact that they can't figure out how to do this every year tells you there's no sustainability because they can't have all this stuff going for the 100-year storm.
Yeah.
Has who sort of done the numbers to look at, okay, calculate we need this X number of doses for a pandemic in developing countries? And then, I guess what I'm wondering is, if with all these negotiated contracts, is there a cushion in there? So if UK says, okay, we're not going to give you 30%, but we'll give you 15%, and everyone else does the same, is there enough cushion so that they can still address? And I mean, not as well as they hope to, but.
So WHO's position is that they have secured 400 million doses per year. However, that 400 million dose number is based on a number of factors. First of all, that all of the contractual obligations will be met in full, which is a problem. But it's also based on the fact that we will be able to, it's based on best case manufacturing numbers, that we'd be able to manufacture 6 billion doses in a year. Most people treat that number of 6 billion doses a year with a huge pinch of salt. So manufacturing is incredibly complex, and we normally get a much lower yield than we anticipate. And that's not taking into account the fact that the egg supply could be compromised. So that 400 million doses is probably unrealistically high. It could be half of that. Even if the contractual obligations are met in full, WHO may only end up with 200 million doses 18 months after the pandemic has started. That's without any governments around the world using these powers. And this is not just a UK issue. Every government around the world will have the power to requisition assets in an emergency and would consider using them and would likely use them, I think, as well.
In a worst case scenario, what ballpark will the demand be? I mean, what number of doses will we be talking about?
So if we're talking about something which requires a 2-dose strategy around the world, just for developing countries or globally?
However you want to present
Everybody times 2.
Yeah, 14 billion.
Well, I'm assuming that, realistically, we know we're not going to be able to get everybody, so what's the target in
70%.
terms, 70% of the population? All right,
So 10 billion doses.
so the numbers they're generating are thoroughly inadequate no matter what.
Yeah.
As a starting point.
Even if best case scenario, no one uses these powers, we get as many vaccines as we could possibly get, we're still in it.
So in the optimal case, we're screwed, and in the more realistic case, we're screwed twice, but we're already screwed, so.
Yeah.
And these numbers
I feel better.
the numbers are a little misleading. You said it, but I think you have to remember that this is doses in a year. And so think about the time to the first dose, but also the time to the last dose.
Yeah.
So that year number, it's a rolling production, so it's after a year, so the virus has already done its thing.
Yeah. And that year only starts 6 to 7 months after the pandemic strain emerges. After we realize this is a pandemic strain that we need to switch onto to switch manufacturing. That switch from identifying we need to target this as a priority to the first dose coming out is around 6 months.
Are there still switch meetings?
Who decides to switch and when is a...
They're actually called the switch meetings, right?
Yeah.
So this I think is that is I think the toughest call in all public health.
Yeah.
And so basically these are dedicated manufacturers. So this is not like a bakery where you can switch and make bread one day and muffins the next. These are dedicated facilities, and you can't bring in some other vaccine plant to make flu vaccine. It's the ones that are making seasonal vaccine. And the assumption then is, okay, if this is the need and there's this lead time that you mentioned, we're going to have to stop doing what we're doing now and then start making the next one. And by doing that, you're basically saying, we're stopping you. There will be no seasonal vaccine now. And what are the risks of that, particularly if you're wrong? And then you have to get started. Because essentially you can't do both. You can't keep both of them going. So you either have the pandemic vaccine that you want or the seasonal vaccine you've ordered. And no one's willing to make that call. So there's been a series of meetings about this. We get closer to it. WHO basically says we don't have the authority to do it. The manufacturers say, just tell us what to do. We don't want to make this decision. And they're sort of in between. in 2009, the decision was essentially made to let the companies, it was in July. So they said, well, you're almost done with what you're doing for the Northern Hemisphere, so just finish that up and then move over. Well, it turns out not everybody was almost done. As a result, there was a huge delay in the availability of vaccine. And back to your point about the models to tell you when things happen, you can project out the number of people who ran into the vaccine long before they would have ran into the virus long before they had the vaccine because of that delay, as opposed to saying, stop what you're doing. But if you tell the companies to stop what they're doing, they essentially lose their entire income for the year because the way these vaccines are made, you don't really have it until the end because they make other components of it. So somebody would have to figure out how their loss is made up. They're willing to do it, but they don't want to take the beating for it. So that decision is still looming, and nobody wants to talk about it because it's too hard.
So the other thing which is worth mentioning is one thing which appears to not have been finalised when you look at the SMTAs which are available and the term sheet of GSK which is put online which shouldn't have been there. There are a number of things which have not been finalised between WHO and the manufacturers themselves. So one of the glaring ones is liability. There's no agreement between the manufacturers who hold these SMTAs and WHO about who's liable for any harms which arise from use of the vaccine. I cannot foresee a circumstance where that vaccine manufacturer would be willing to ship to WHO for onward transfer to developing countries without that being agreed and without having reassurance about where liability for harm arising actually lies. Liability for use of the vaccine between the UK government and the manufacturer is pre-established for a pandemic event. So there will be a very quick negotiation about who remains liable, with whether the UK government or the manufacturer is liable for rollout of this vaccine and any harms which arise for it. That hasn't been agreed between WHO and the manufacturers themselves. I cannot foresee any manufacturer shipping until they have that agreement in place.
In 2009, the manufacturer said you can't have it unless you solve this.
Yeah.
WHO said we can't solve this. So they made every country said if you want to get it, you country, have to guarantee liability protection. They had no idea what they were getting into, but they knew that they would get nothing unless they signed.
Yeah.
Not knowing what the full implications would be.
But there is example also in the way that how it was provided to Latin America and the Caribbean, since most of the countries they got it through the PAHO's revolving fund.
Yes.
The PAHO revolving fund made the manufacturer to be the one responsible for the liability.
Through PAHO?
Through PAHO.
Only because by the time they got it, they were pretty sure it was safe. At the beginning, so that's fine. But the reason was they felt that their risk was a lot lower than had they done it earlier. Earlier on, that wasn't the case. The revolving fund covered it late because they said, okay, it's probably okay.
That's right, but also we know that from the countries in the region that they got it from WHO, the nation, it arrived later than the ones that they got it through the PAHO revolving fund.
That was the one advantage of being late in the line.
So I'd like to bring in one more complicating factor.
Oh, great. We need another one.
That's the uncertainty that is always present at the beginning of a pandemic. You know, I think that in 2009, you know, what you put up there in terms of the risks, in the spring of 2009, we would say, oh yeah, this is something that meets the criteria.
Yeah.
By the fall, a lot of these things had been resolved, and it was turned out the case fatality rate was far lower than had been feared.
Yeah.
And so, you know, in a way, the UK and other governments with that kind of thing could have declared emergency powers at the beginning. Fortunately, they didn't.
Mm-hmm.
But they really didn't meet the criteria at the end when
the
vaccine became available.
Yeah, and it goes back to what Chris was saying. The more severe, the more likely this is to occur, and they're sort of mutually reliant upon each other. During low-level, non-severe events, things like 2009, which was not that severe, it's unlikely these powers would be used.
My point is that what we know about the severity is not clear at the beginning.
No. At which point we won't have a vaccine to requisition anyway. So it's only once we get to the point that we're assured that there is a serious event which we need the vaccine for, would we be in a position to use these requisition powers.
Switch call, because if you call it early to get things going, you got to call it early.
Yeah.
But you can't go back.
No, you can't then turn the switch back over. Yeah.
You're committed, and now you're playing it out, and then you have no vaccine that was going to happen. The seasonal vaccine. You're making a vaccine which people think is less valuable, and imagine the politics and the optics of that one.
Yeah.
So how can we use the coronavirus outbreak here as some sort of like, for instance, let's say use the same vaccine production capacity. You know, would this be enough of a scenario right now to make that switch? Would it, you know?
No, so there's, so it's not clear what kind of vaccines will be made. They're not gonna be made in eggs.
Mhm.
So influenza vaccine capacity is not gonna be used for, I don't think there's anybody making an egg-based vaccine for coronavirus, so it'll be something else.
There's nothing out there at all. So, but I think it's,
There's a lot of ideas, the question is.
yeah, there's a lot of ideas, but I
what's
think it's an interesting thing to consider, like, is this scenario right now, is this something that you could conceive of being, you know?
An emergency in these circumstances.
But you're not, but the emergency, but what are you stopping?
Yeah,
What are you shipping?
in terms of having,
Small facilities, pilot lot facility levels, there's not existing, I don't know, there's not really existing capacity that's gonna be in place that a government is gonna have enough capacity, enough volume for their own citizens. They may do it in ones and twos, but it's not like the existing global.
Right.
Are you saying maybe if we took the pattern of the current outbreak and said, let's assume
That's
this
what I
is
mean.
influenza rather
Is this
than
an
coronavirus?
emergency?
would this count as an emergency within the UK framework?
I think also, on my point of uncertainty, we need to make sure we do everything we can to resolve that uncertainty as quickly as possible.
Yeah.
Like Mark Lipsitz, just had a paper in New England Journal the other day about what we don't know about how the COVID is evolving and the need to fill that in.
Yeah.
Okay.
I think
But I
it,
think
to
But I think your point about using this, what's going on now, to start thinking about all the ramifications of this are really critical. Among them is, if there's limited supply, not just which countries get it, but who within any country gets it. And how do you figure that out? And then how do you execute that to get the right people in the front of the line?
One thing, to feed into that, one thing which hasn't been resolved from WHO's perspective is once they get these doses, let's say they actually get 15% of the real-time production from the UK, where they're shipping that is not known. Which countries will actually receive vaccine, in what order, and on what basis that will be decided, what factors will be taken into account to decide this lot is going to Algeria and not Albania, is not part of PIP and is not decided. And how that will be decided remains totally unknown at present.
Bruce brought up a point, and I know Chris wants to jump in.
I have a stupid question, but it's a really ignorant one.
That's wrong.
Yeah.
Well, let me just, you brought up a point that's always bothered me, that, at least in the US, especially for influenza, we have an entire process and committees that need to decide prioritization. And I never quite, but yet if we shipped, there wouldn't necessarily, it didn't come with that prioritization standard. Like it wasn't,
So the prioritization, it's posted, you can read it, nobody knows it's there. But essentially every American is listed in there somewhere, either because of what job you have or because of your medical condition or not. So that's all there. Not there is the export part. So the only difference would be that there's that much less to give to the US citizens, but there's not a discussion about the export piece.
so if the US donation went to Algeria
Well,
and
the
they
US
decided
so
not
what
to
happened,
vaccinate pregnant women or.
well, so the US decision in 2009 was, let WHO figure it out. Because you're gonna make, the idea of, from a political standpoint, you're only gonna make more enemies than friends, because by trying to pick and choose the various countries alphabetically, by height, by color, by God knows what. So they said, WHO, you figure it out. And so that was your point, is they had sort of a plan, but it was based on process. You had to have a letter of intent, you had to have liability protection, and probably the most important thing is that countries had to demonstrate that they had a vaccination plan, because nobody wanted to ship this stuff where it sat in a warehouse somewhere.
Which is what did happen during 2009.
No.
To small doses, small number of shipments.
That happens, but so in 2009, among the problems was the volcano in Iceland. Amazingly, that sort of set off air disruption. So air traffic was down for a while. So plans to ship stuff got screwed up. But there wasn't a lot that was sitting on docks. Very little went out. I think 83 million doses was something like that. So 83 million doses is all that WHO ultimately distributed over a period of time that didn't start until January 2010, and then dribbled out after that. So it was, to your point, of it's not never, but it's really little and it's really late. But it was up to them to sort it out. They tried to do it a little bit by hemisphere because of the way flu travels. Unlike other things, it's hard to do it regionally. You might be tempted to send it to Asia now, but as this is full blown, it's everywhere, so it's not quite as simple as sending it to the region of need. But it was up to WHO to sort that out on who knows what the
actual criteria,
were.
yeah.
But you had to show that you were interested, and you had to have liability protection, you had to have some vaccination plan. But WHO didn't grade your plan. They didn't care if you gave it to the military or the royal family or to people born on a Thursday. You just had to have a plan.
Mm-hmm.
My stupid question is just to the extent that various obligations on the producers, et cetera, are triggered when it's a pandemic strain, to what extent does that lead to the risk of significant sort of political pressures being brought to bear on whether or not a determination is made and when that something is a pandemic? And does that matter?
Does that matter for the operationalization of these agreements? I think by the time we get to the point of any of this occurring, we will know if this is a genuine, real pandemic or not. As to the political pressure of that point, I think one of the interesting things is that PIP and the transfer of the viruses through PIP applies only to influenza viruses with human pandemic potential, but that's not defined within the agreement. So it is down to end users who are putting viruses into the system to make a determination as to if this virus has human pandemic potential or not. So if it has human pandemic potential, you put it into the PIP system through GISRIS and you share it with WHO and collaborating centers. If it doesn't have human pandemic potential, you can make bilateral transfers, you can carry on transferring it and shipping it the way that you ordinarily would in terms of virus shipping.
Unclear who makes that determination.
Yeah, it's not clear how that is decided, on what criteria and by whom. It seems to be quite ad hoc. There's no guidance within PIP about that.
So in 2009, the WHO had this 1 to 6 phase pandemic, flu pandemic, and a lot of the countries had contracts or at least plans to buy vaccines when they got to level 5 or level 6 or something like that. And they were triggered early in May. And then, of course, by the time that the vaccines were ready to be delivered, it was clear they weren't needed.
Yeah.
And
So
that caused a big problem.
That was the issue with the UK Advanced Purchase Agreement. That's triggered by if WHO says this is level 5 or level 6. And the terms which we know about within the contract are that it secures between 32 and 120 million doses for the UK government, which have to be fulfilled prior to any other vaccines rolling out. So the UK government triggered this contract with manufacturers based within the country, ordered the full dose, because at that point early on in the spring we thought this looks like it could be a pretty serious big pandemic, and then reneged on, tried to back out of the contract and go, oh no, actually we didn't want to trigger it, we don't need anywhere near as many of those vaccines as we thought we did. So they're very flexible, the advanced purchase agreements which developed countries have with the manufacturers in their country. It secures anywhere between enough for 1 dose for half of your so the population of the UK is about 60 million, so we can guarantee between 30 and 120 million doses, which is pretty much the entire yearly supply of what is manufactured in the UK in one go.
But the WHO doesn't have these same 6 phases anymore.
No, they don't. No.
So it is 8:59.
Oh wow.
I know, right?
That flew.
Sometimes we get kicked out of this room, sometimes we don't. But I do want to make sure that you have a chance to if you have a last thought.
So WHO looks very highly upon the PIP framework as a model that is a good access and benefit sharing regime, and has talked about expanding the model to other pathogens, and also include expanding it to possibly include seasonal influenza viruses as well. My worry is it's a model that will fail when we need it the most, and that's quite a sort of scary thought to end on. But thank you all so much for coming. I really do appreciate it.